The following podcast was recorded at the ANZICS Safety and Quality Conference 2014 Rapid Response Teams. Jennifer Hill talks about National Standard 9 and essential elements for recognising and responding to clinical deterioration.
I'm the bureaucrat, though I used to be one of you. I was once an intensive care outreach nurse, so I'm very interested in the innovations, but I'm going to talk about bureaucracy. So I work for the Australian Commission on Safety and Quality in Healthcare. My name's Jenny Hill, and I'm a senior project there for the Recognising and Responding to Clinical Deterioration program. I'm going to start by giving you a bit of information about the Commission, just in case you've missed the highlights of what we do. And then I'm going to talk a little bit about where Standard 9 came from and what I think the role of intensive care is in the bigger picture of systems for recognising and responding to clinical deterioration. So the Commission was established in 2006, initially as a kind of temporary body, and its role is to lead and coordinate safety and quality at a federal level. It is half funded by the states and half by the federal government, so it works very much through processes of consultation and collaboration. It's not a service providing organisation, it's about knowledge sharing and about things like setting standards and developing the National Safety and Quality Health Service Accreditation Scheme, which I'm sure all of those who work in Australian hospitals are well aware of at this stage. So those are some of its functions there. The program that I work for, as I said, is about recognising and responding to clinical deterioration, and obviously this is a very well-educated audience, so I'm not going to go into great detail here, but essentially we know that there's lots of evidence that people in hospital deteriorate and that potentially preventable harm can result if those signs of deterioration aren't recognised or acted on. And we also know that there are some well-established strategies that can be implemented. Now, when the R&R, it's R&R for short, it's a bit of a mouthful, program started, those well-established strategies were established but often without evidence or with confounding evidence. So things like the merit trial where people were still debating about whether MET actually worked or not. Thankfully, I think we've probably moved on from many of those debates. The reason I think that the Commission felt that there was a role to play at a national level was about the sort of systemic change that needed to happen to put systems in place that actually made a difference for patients. So it's about taking a systematic approach, and one of the first pieces of work that the program developed was the National Consensus Statement. So the National Consensus Statement was endorsed by health ministers in 2010 as the Australian approach to recognising and responding to clinical deterioration. And it was developed very much in conjunction with a lot of the people who are in this room. So we had a lot of expert advice from the intensive care community through the development of that work. Most of the work that I'm talking about today is work that is not my own and is work that's very much come from the clinical world and has been interpreted into policy speak. The National Consensus Statement essentially describes 8 elements that are considered to be essential for systems that promptly and reliably serve patients who are deteriorating in terms of recognising and responding to their circumstances. The consensus statement applies in all kinds of acute settings, so that means that implementation of the elements really needs to be tailored to local circumstances. So I think various speakers today and yesterday have spoken about the need to take the systems and apply them given the resources that you have and the needs of the patients that you serve. And I think that's a pretty key thing to think about when you're thinking about how to do this stuff. Certainly the consensus statement outlines kind of what you need to do, but it doesn't tell you how you need to get there. And the scope is as you see there. So in brief, the 8 essential elements, the first 4 of them are about the clinical processes that occur at the bedside. So what happens to recognise someone's deterioration, what needs to happen there in terms of monitoring vital signs. So essential element 1, which is about the measurement of vital signs. In that element, the sort of 6 vital signs that were considered to be essential are outlined. And It's also outlined that every patient needs to have an individualised monitoring plan that is appropriate to their circumstance. So that's in there. The second process is about escalation, so providing some clarity in your hospital organisations about who, how and when to call for help. And then the third element is about the rapid response system, so obviously the stuff that you guys are all here to talk about more than anything else. The remaining elements are really to do with the systems that need to be in place in the background. So what are the systems that the organisation needs to have in place to support clinicians to provide those clinical processes at the bedside? Nicola, who is my boss, Nicola Dunbar, who originally developed this consensus statement, wishes that she had named organisational supports governance, because that's really what that means. And I think that that is pretty key in terms of organisational supports. You need to get the governance for this stuff right, or you're going to fail. I think that's a pretty clear message that we've learned since the consensus statement has been out and about in the world. So the consensus statement really was the foundation document for the development of Standard 9. There are 10 National Safety and Quality Health Service standards, and they were developed really with the aim of protecting the public from harm and for improving the quality of health service provision in Australia. They became mandatory for the accreditation of Australian health services as of January 2013. There are two overarching standards, so they're the things that apply regardless of what else you do. And the first of those is about governance for safety and quality, so it's about having the systems in place that mean that you're measuring what you do and feeding that back to the right people. And the second of those overarching standards is about involving consumers in the governance of organisations, so it's actually about having the people who you serve engaged in designing your services. The remaining 8 standards address specific clinical aspects of patient care, and they all include actions to incorporate a patient-centred approach to care provision, but they are about specific aspects of patient care. Standard 9, it comes in 4 parts, which we'll go through in a bit more detail in subsequent slides, but essentially it describes the systems and processes that need to be in place to effectively respond when someone's clinical condition deteriorates. And it was developed very much in the context of the National Consensus Statement, and it requires that systems are consistent with the elements outlined in the Consensus Statement. So if you haven't read the Consensus Statement and you're trying to implement Standard 9, I suggest that you go there. So the reason that we have a standard about recognising and responding to clinical deterioration is that always in health, I think there is a lag time between the innovators and the spread of best practice. It's a well-known phenomenon. And this is essentially the reason that this stuff matters. So this quote is from the coroner's report on the death of a 38-year-old woman who died after developing a postpartum bacterial infection in WA. Their coroner's reports are a rich source of how to get it wrong. And basically it was one of those catalogues of disasters, but one of the key components that led to Susanna's death was the fact that despite the fact that really abnormal observations were being recorded, the nurse said that she wasn't aware of the Code Blue criteria, and because Susanna was able to talk and wasn't actually dead yet, she didn't think that she was in trouble. I interviewed an eminent professor of intensive care who is here today, who shall remain nameless, about his views on end-of-life care in hospital some time ago. And he told me that he didn't really understand the purpose of policy. And I think as an ex-clinician, I understand that view. But really what I think is that the purpose of policy is to spread the patient safety initiatives that innovators like many of the people in this room have developed through the system. So it's about spreading the message to the laggards, I guess. So back to Standard 9. The sort of first part of the standard is really about organisational support and executive and clinical leadership, which, as I said before, is absolutely necessary for successful implementation of these systems. And it's about developing systems that are consistent with what's in the National Consensus Statement and making sure that those are clearly articulated as the way that we do things around here. Second part of the first part is about collecting information and providing feedback to the people who are actually doing the work. As a number of people have emphasised during the last couple of days, the people who are providing the care are the people who have the power really to influence the way that care is provided. So if you don't tell them how they're doing, they can't make good decisions about how to change what they're doing. So I think it's a pretty key component of the standard. I think, just from the intensive care perspective, I think the people in this room are often the owners of the data. They're the people who actually collect it. So I talked to a range of intensive care nurses in particular who are involved in the Met systems, and they spend a lot of time collecting data. And then with their interdisciplinary colleagues, they spend a lot of time interpreting that data. But certainly some of the people who I've spoken to don't have anywhere for that data to go. And I think that's the key next step, is closing that loop. I think a lot of people are doing great work and publishing it in forums like this, but actually sometimes that data isn't getting back to the ward staff or to the executive. And I think that's a pretty key thing to think about when you're thinking about the governance for your systems, is how do you influence practice change and how do you influence the bean counters to give you the resources that you need. And I think often data is power, so it's important to use it. The next part of the standard really is about recognising deterioration and escalating care. And we've certainly heard a lot about various models for rapid response systems yesterday and today. And as far as the Commission is concerned, we don't really care what system you use as long as you have one. And I think, again, intensive care probably has a very vested interest in being involved in developing effective systems, given the role of responders when things go very badly. And also from a patient-centred perspective, I think we all have a role in making systems better in terms of keeping patients safer. And intensive care is the repository of a lot of knowledge about how to manage sick people. And I think it's very reasonable that that knowledge is shared. One of the key stumbling points, I think, in Standard 9 for many organisations has been the implementation of track and trigger charts. And again, I think people get very caught up in the chart as the thing that actually matters. And I would say the chart is a tool, and the thing that actually matters is the system around the chart. So I think it can be very dangerous to get too bogged down in the details of what your chart should look like, or what system you should use, or what the parameters should exactly be, when you're missing the point of what is the system that is built around the chart. And I think that's a really important thing to consider when you're thinking about which kind of chart you want. Escalation policies and protocols obviously need to provide very clear information about what to do if deterioration occurs, and some of the escalation policies that I have read are pretty hilarious in patches because they seem to have some big gaps about what to do at night, and I would say that that's one of the key areas to think about, is what to do at night or after hours. The other thing about escalation policies is, I think we heard Ken talking about with the merit trial, people sending around an email on Friday and implementing a system on Monday. And with the pressure of trying to meet the standards, I think, again, it's some health services are tempted to just rush to implementation, and you actually need to think about it as a system-wide change process, which is much more complicated and is simply not something that can be done in haste. The third part of the standards is about the response to clinical deterioration, and I'm not going to labour the point here. Basically, I would say I'm very interested to see the results of the after lunch research session that we did yesterday. I think it'll be really interesting to hear about where you guys think the escalation processes go wrong, and whether the response systems that we provide are actually meeting the needs. Is there some kind of gap between those two things? It'll be very interesting to hear about. The final part of the standard, I think, is something that is the future, regardless of the clinical process that you are undertaking, and that's about patient-centeredness. I certainly think that in the work that I've been doing recently about end-of-life care as well, the biggest gap that we have in the way that our systems serve our patients is in failing to be adequately patient-centred and in failing to be adequately goal-directed. And I think that those things are inextricably linked. And I certainly think that we all need to start thinking about how we can serve the needs of our patients and their families and carers in a more sophisticated way. I think often we pay lip service to this stuff, but we need to think about doing this in a very meaningful way and using models like shared decision making to help us to achieve that. Again, I think the REACH program and other similar programs that are looking at patient and family escalation are going to be very interesting to follow in the next few years. It'll be very interesting to see where the research goes there. And again, I think it's really important to acknowledge the sort of leadership that many intensivists have shown in this area in terms of developing programs and setting the research agenda in terms of what is happening to patients whose deterioration shouldn't be escalated necessarily to the rapid response team because their deterioration is in fact likely not to be reversible. So I think programs like the Respecting Patient Choices program and so on, again, it's going to be interesting to see where those things go in terms of furthering the patient-centred agenda. So I've nearly finished with the bureaucracy. The next steps for the Recognising and Responding to Clinical Deterioration program, the big portion of work that I've been focused on in the last 18 months or so is about the safety and quality of end-of-life care in acute hospitals. So I trailed around the country a while ago and spoke to many of you about your experiences of providing end-of-life care in hospitals, which was very interesting work to do. And a background paper was released in August last year. Since then, we held an expert roundtable meeting with, again, some of you in the room to develop the framework for a second national consensus statement, which in this case is about the essential elements of providing end-of-life care in the acute setting. The consultation process for the draft of that document has just closed, so I'm in the process of reviewing that document now, and we hope to send it along the bureaucratic pathways to health ministers by the end of the year, so that should be coming. The other piece of work is we have just closed a consultation process about Action 9.6.1 of the standards, which at the moment is requiring that all clinicians are trained in providing basic life support, and we are considering the process of reviewing the standards for 2017, and I think one of the key things that we need to think about is whether basic life support is actually intervening early enough in the trajectory of deterioration, so whether that is in fact the appropriate training for people who are providing patient care, or if we need to think about what the minimum standard should be further up the trajectory. As I said, the standards are starting to be reviewed as of 2015. So we need to start thinking too about the scope of Standard 9. There's another piece of work that's happening at the moment looking at the applicability of the consensus statement in terms of recognising and responding to deterioration in mental state. You can imagine that's a pretty complex piece of work, so it will take some time. I'm going to finish by showing you a cartoon because I think no talk at a conference like this can be without a cartoon. And I think that many of the innovators of this room have been offering the system a pair of wheels for quite a long time, and the system has spent a long time saying no thanks. So there's my obligatory cartoon. It's hard to find a cartoon about policy.
For more podcasts from ANZICS, go to anzics.com.au.